Hi, my name is Laura Fields, and my presentation today is on adolescent idiopathic scoliosis. If you've ever seen the movie Forrest Gump, and when he's a kid, he has those braces on his legs, that is because he has adolescent idiopathic scoliosis. Scoliosis is a lateral curvature of the spine recognized clinically for centuries, and the cause of most scoliosis is unknown. Idiopathic scoliosis is just a term used in medicine to describe something that arises without a cause. Since 1922, 2.5% of Americans have been diagnosed with idiopathic scoliosis. The three distinct peak periods of onset idiopathic scoliosis are subdivided into three groups. And they overlap sometimes for age groups. And the first group is the infantile stage, and that is when diagnosis is before 3 years of age. Then there's juvenile, which is ages 5 to 8 years old, and adolescent, which is what I'm mainly going to focus on, which is between ages 10 and until the end of growth. Adolescent idiopathic scoliosis is present in 2 to 4% of children between ages 10 to 16. It's defined as a lateral curvature of the spine greater than 10 degrees and accompanied by vertebral rotation. My thesis is the cause of adolescent idiopathic scoliosis is unknown, and all diagnosis and treatments are aimed toward the prevention and correction of the spinal deformity, but it is unclear whether treatment is permanent, and if the cause of AIS were to be identified, predicting progression could be improved and more specific treatments could be developed. My objectives today will be, we'll talk about prevalence, diagnosis, then we'll talk about the evaluation of growth potential and the magnitude of the curve, and then we'll finally talk about non-operative treatments, operative treatments, and treatment outcomes. The prevalence of scoliosis is between 2 to 4% of children in the ages between 10 to 16. Ratio of girls to boys with small curves of 10 degrees is equal, but it increases as the curve progresses greater than 30 degrees. The ratio for every 10 girls is 1 boy. Scoliosis tends to progress more often in girls, and then therefore girls need more treatment more commonly than boys. 0.2% of cases have curves greater than 30 degrees, and 1% of cases have curves greater than 40 degrees. Once the diagnosis of scoliosis has been made, there's two primary concerns. The first is whether there's an underlying cause, which if they have idiopathic, that means their cause is unknown, and if the curve will progress. Three main determinants of the progression are the patient's gender, the future growth potential, and the magnitude of the curve at the time of diagnosis. In all cases, females have a higher risk of curve progression than males, and it's 10 times higher. And the greater growth potential and larger of the curve, the greater likelihood of curve progression. The evaluation of growth potential is done by assessing Tanner stages and the Rizzer grade. The Tanner stage assesses the onset and progression of puberty. Stages 2 to 3 is the onset of puberty, and that is when the maximum progression of scoliosis generally occurs. The Rizzer grade gives useful estimate to how much skeletal growth remains. The grades are from 0 to 5, where 0 being no ossification and 5 being complete bone fusion. The magnitude of the curve is best determined by the Cobb angle, which is derived from a standard posterior-anterior standing radiograph of the spine, which means that it's a picture of an X-ray would be taken from its back to front if you're looking at it. And the Cobb angle is formed by a line drawn at the superior, which is the top vertebrae of the scoliotic curve, and there's also another line drawn along the bottom of the inferior vertebrae. And then there are two intersecting lines that are perpendicular to those first lines, and where they intersect, that's where the Cobb angle is. Non-operative treatment varies internationally. Treatment in the U.S. is with patients that still have growth remaining. There's watchful observation followed by bracing if the curve progresses greater than 25 degrees. In European countries, the use of physical therapy goes along with bracing, and that's believed to be the best treatment route. The expectation of treatment with bracing is to prevent progression of the curve until the patient reaches skeletal maturity, and at that time the risk of curve progression greatly diminishes, which also lowers the risk of need for surgery. There's no definite evidence shown that physical therapy or bracing reduce the risk of curve progression, that it corrects the existing deformity, or that it decreases the need for surgery. The medical community has arrived at two different conclusions. Some believe that the evidence favors positive effect of bracing, and others believe that the evidence is poor and inconclusive. The primary objectives with surgical treatment with instrumentation are to arrest progression, achieve maximum permanent correction of the deformity in 3 dimensions, improve appearance by balancing the trunk, and keep short-term and long-term complications to a minimum. The generally agreed indication for surgery in adolescents is a primary curve of a Cobb angle greater than 45 degrees. Adolescent patients can choose to delay surgery until they're adults, but if they do so, adults tend to have a less flexible curve than children, which means that they could need a posterior and anterior procedures done to them, and the rate of complications in adults is much higher for the same procedures than it is in adolescents. And medical advances in the surgery have made it much safer than in the past decades by improving preoperative assessments, intraoperative neurophysiological monitoring, and blood salvage techniques. The advancements of solid bony fusion, which keeps the spine in place, have been achieved through autogenous bone grafts, allografts, demineralized bone matrix, and the latest biological bone substitutes. Posterior instrumentation is generally the treatment that is used for most idiopathic curves. The procedure includes a use of combination of hooks, wires, and a lumbar pedicle screw that's constructed over contoured rods along the spine, and they are all tied together with an interconnecting system applied over several posterior sites, which include the lamina, the pedicle, transverse processes, and the spinous processes. And the procedure has been able to advance multiplanar correction in the coronal and sagittal transverse planes, stable fixation, reduced levels of fusion, and avoidance of post-operative immobilization with a cast or a brace. There are 3 different types of treatment outcomes that are reported with surgery, and there's radiographical measurements done in the coronal and sagittal planes, and there's also clinical reports that show complications, pulmonary function and symptoms, mobility, muscle strength, and back function. And then there are self-reported outcomes, which are just general health concerns specific to scoliosis and its treatment. In conclusion, adolescent idiopathic scoliosis is a lateral curvature of the spine greater than 10 degrees accompanied by a vertebral rotation. It occurs in children ages 10 to 16, and the cause of adolescent idiopathic scoliosis is unknown. All initial diagnosis and treatments are aimed towards the prevention and correction of the spinal deformity, but it is unclear whether this treatment is permanent. If the cause of AIS was identified, then predicting progression could be improved and more specific treatment could be developed. These are my references, and thanks.